Welcome back, everyone. Now we're gonna speak about the OCT, which is one of the highest deal topics in any exam now and in your practice as well. Remember, this is a crash course. It's not supposed to make you learn how to do it. It's just there for you to be able to know what comes in the exam, focus your studying to achieve high pass marks. So what you need to remember are the many retinal layers that we have. The retina is in the back of the eye. Let's start from the basics because it's very important to remember your basics to be able to understand the OCT. So we have 10 layers in the retina. All of them are very hard to remember in the beginning, but let's simplify the whole situation. You have 3 types of cells in your retina. You have the photoreceptors that receive your light, and then you have let's call them translating cells in between your main photoreceptors and the cells that will go into your brain, the ganglion cells that form the optic nerve. So you have 3 types of cells communicating together in the back of your eye. One of them will receive the light. They are the longest cells there. They have many segments, and these are the ones that respond to your light. Then they communicate with the bipolar cells in the middle to adjust what they received and understand more about the whole light that they received and the colors and the contrast. It starts to be translated at the bipolar cells. And then the bipolar cells will then send the information to the ganglion cells. So these cells have cell bodies and then have dendrites or terminals to communicate with each other. So if you have the cell bodies, this is a nuclear layer because it has the nucleus of the cell. But if you have dendrites and webs of cells, terminals communicating together, this is a plexiform layer. And according to their site in the eye, if they are near the sclera, then they are outer. If they're near the inside of the eye, then they're inner. Let's have a look on our photoreceptors. As I told you, they have many segments. We have outer segment, we have inner segment. And we have a small junction between. You may think that this is not important. However, this is one of the very important layers that we will talk about in the OCT. So we have outer segment near the outer portion of the eye, and then we have the inner segment, and then we have cell bodies, and then their dendrites will go up to make the outer plexiform layer. Let's take a histological section of your retina. So this is the histology of the retina, and this is the diagram, just similar to the ones we saw before. So it is very important to understand this histological section because basically the OCT is taking an optical section. So what I'll tell you again about the layers, please, try to memorize them with me. So you first start with your retinal pigment epithelium, basically above the urochoroid. This is the base that all the cells will lie on. Then you have your photoreceptors. There's their inner segments and their outer segments. And if you can appreciate the difference in the color between the inner and outer segments, it's like there is another line in between that can differentiate between the segments of the photoreceptors. And then we have their cell bodies. This is the outer nuclear layer. And then they send their terminals to communicate with the next layer. So it will be the plexiform. Since we're near the outer layer of the eye, this is the outer plexiform. And then we have the cells of the bipolar in the inner part of the eye. So this is the inner nuclear layer. They send their terminals as well to communicate with ganglion. So there is the inner plexiform. And then we have the ganglion cell layer, and then the nerve fiber layer. What I want you to appreciate is how crowded the nuclear layers are, full of cells. However, you can still see some spaces between the cell bodies. But if we look at the plexiform layer or the nerve fiber layer, there is no space. So if you are sending light through this area, through this tissue, the light will find it easier to walk through the nuclear layers. So these will always be passing the light very nicely. However, the light will always find resistance in any plexiform or nerve fiber layer. And of course, if you have pigments, this will reflect the light. Remember the difference between the rest of the retina and the macula, that we have one special layer called the Henle fiber layer, which is basically your plexiform layer, but because it's shifted to the sides to have the fovea, it's given a different name, and it's very important on the OCT as well. So here is one of the very high yield simple questions that you can get an easy mark for. The Henle fiber layer corresponds to which histological layer? It is the outer plexiform. So the OCT, which is the optical coherence tomography, meaning you can take an optical section instead of histological section. So optical is using light waves. Coherence is applying the principle of coherence or interference between light, and we'll understand about that. Tomography is taking a cross section. So you're basically taking cross section inside your eye, but with light waves. It is a very exciting new diagnostic tool, and it can give you axial resolution of less than 10 microns. So we have many types of OCTs. Again, if you remember with the ultrasound, we said higher frequency means better resolution and less penetration, and the frequency is equals 1 over the wavelength. So if you have longer wavelengths, you have better penetration. So we want better penetration inside the eye because we have a retinal pigment epithelium full of pigments, and we want to see the choroids, which will be called the enhanced depth OCT. So we use longer wavelengths. Let's see how the evolution of the OCT. It started with a type called time domain OCT. This time domain could give us 400 A scans per second. So it will do like the ultrasound, an A scan, do 400 per second. We used to use a diode or 810 nanometer, and it was giving us 10 micrometer axial resolution. And then we developed the spectral domain, in which can give us 20,000 A scans per second. Imagine the amount of information you're collecting per second. It's huge. And then you have the same wavelength, so the resolution was yes, a bit better, but not very much different. The most updated now is the Swift source. It can give you 100,000 A scans per second, and you have a tunable laser that can change its wavelength, so you can have up to 1050 nanometers, so it can give you up to 5 micrometer resolution. What you need to know for the exam: the OCT principle is interferometry. What does that mean? It means interference of light waves together. So they might give you this image over here. This is like a simplification of how the OCT works. So you have the light source here that shines into a beam splitter. This beam splitter splits the light waves that you're sending, one into the eye and one into a mirror, and then both of these are collected back, and then they make a pattern of interference, and with an algorithm called Fourier transformation you can get the OCT image. So the combination of light reflected from a tissue of interest and light reflected from a reference path or the mirror will produce a characteristic interference pattern, and that will let you know, is this tissue hyperreflective, is it hyperreflective, and so on. So the resulting plot of this is having exactly an A scan. And then we're going to have many A scans very fast, as I told you, and that's when you get the B scan or the OCT image that you're used to seeing. Just to make you understand or appreciate how fine the OCT is, this is a comparison between the OCT and ultrasound and CT and MRI. So MRI is very good. You can see the entire body. So you have full penetration of the body, and the resolution is about 1 millimeter. But let's see the OCT. It can only penetrate about from 1 millimeter to 1 centimeter in between them, which is very poor penetration. However, it can give you a resolution between 2 to 10 micrometer. It can give you a very good image of the posterior segment, all its layers, as well as the anterior segment. So the anterior segment OCT is not a very high yield topic. in the exam, but I imagine that if they want to ask you something about it, would be why use an OCT anterior segment and not an ultrasound, or which one to use if you have a patient. Do you send him for ultrasound by microscopy, or do you send him for anterior segment OCT? So the difference is, as you know, the ultrasound you're using sound waves, the OCT you're using light waves. So the light waves, when they meet the pigment epithelium of the iris, they will be reflected back. You will not be able to see anything behind the pigment epithelium of the iris. So if you're looking to diagnose something in the ciliary body, then the ultrasound by microscopy is the way to go. But if you're looking at the angle, if you're studying the cornea, anything like that, then pick the OCT. Definitely, it's not invasive. You're not touching the patient. The patient is sitting upright. It's very fast. So just knowing that this is a light wave that will have a limit at the pigment epithelium of the iris, and this one will penetrate deeper and give you good imaging of the ciliary body. These are the two the main differences of the OCT and by microscopy, ultrasound by microscopy. So this is the basic image of the OCT. Whenever you see that, or whenever I saw it before, it always creeps me out that it has so many labels and all of them will just merge together. But we will simplify how they are, and you'll be able to identify them without going through the 10 layers. Let's see how we can do that. First, let's look at these white lines here, which many people assume it's just one line and that's the end of it. However, if you have a very young patient with very clear media and very good cooperation, you have a very good quality of scan, you'll see that there is actually about 4 white lines over here. That's a lot of white lines. So what are they? We're going to split them in 2 because these are actually just 2 layers, but different parts of them. So the first 2 layers here, the lower one is the base of the RPE, and then the upper one is the upper edge of the RPE, which is called the interdigitation zone, because the upper edge of the retinal pigment epithelium is just consists of fingers like this, hugging the photoreceptors. So this is the first one will be the base of the RPE, and then this is the interdigitation zone, or the upper border of the RPE. And then we have like a black area over here, and then a white line, black area, white line. Does anyone know what is this black line that usually appears in the center of the OCT? It's not very evident on the sides, but under the fovea, you can see this black area. Does anyone know what it represents, or is it normal? I'm sure you've seen it. If you're practicing ophthalmology for a long time, you've seen it and said, yeah, that's normal. But why? What is it? Does anyone know? Okay, well, I thought everyone was sleeping. Thank you guys for responding. So this area is actually the outer segment of the cones. Studying the anatomy, we'd know that the cones, one of the adaptations of being in the fovea is that the outer segment of the cones gets so much elongated. So this white line is the difference, is the inner segment, outer segment junction, the small thing that I told you about. Remember, let me show you. So remember this area. So this small, tiny thing is this very nice white line, the inner segment, outer segment junction. So this area is an elongation in the outer segments of your cones, usually means that this patient is young and healthy, and the cones are very, very well formed and very mature over here. And the cones then on the sides return to their usual length. So that's why you don't have this black area on the sides of the fovea. So again, let's go back. This line is the inner segment, outer segment junction. Other books will say this is the photoreceptor integrity line. This is because it is very important in determining the prognosis of your patient. So this segment, this very nice white line, if it's not there, then you can know that the prognosis is not very good. If it's still preserved, even if you have macular edema everywhere, even if the other layers are in complete chaos, you can still say there is a bit of hope there that the patient will be able to see again. And then the last line over here, this is the external limiting membrane, which will be just below the cell bodies or the outer nuclear layer. So I hope you now know all these white lines, what they represent, and this will help us diagnose any image you can see from the OCT. So again, let's say the layers that we have. I'm going to show you each layer again. So when we show the abnormal pictures, you can guess where the pathology is and so get what the pathology is. So we'll start with the large black area. This is the sclera. And then this is the choroid. And I want you to appreciate the thickness of the choroid, because in many diseases, the choroid is thickened and will help you diagnose the disease as well. So let's start. The black area is the sclera. Moving on to this area, this is your choroid. And then we have the 4 lines we talked about. The first one is the RP, the base of it. And then the second white line, it is the interdigitation zone. The second one is the outer segments. And if you can see here, the elongated outer segment of the cones is more appreciated under the fovea than anywhere else. And then you have the myoid zone, or the inner segment. And then the line is the external limiting membrane. And then you're supposed to have the outer nuclear membrane, which has a cell bodies. Cell bodies will send the dendrites, so you're going to have the outer plexiform. But since you're in the macula, we'll call it first the hem fiber layer, followed by the outer plexiform, then the inner nuclear layer, the inner plexiform, and then after that, you're going to have the ganglion cell layer. Then it's nerve fibers moving in thickened on this side. And then you have these areas, which is first the internal limiting membrane. This is the pre-retinal space because the vitreous have left the retina in this small area. The posterior cortical vitreous. And then this is the formed vitreous, your vitreous over here everywhere. I hope now you can realize the layers of the OCT better. As I told you, if you remember, that the nuclear layers are rounded structures with spaces in between, so they are hyporeflective. So this is, when you see a hyporeflective space over here, this is a nuclear layer definitely, and if it's near the outer side of the eye, this is the outer nuclear layer. If it's this one, if it's near the inside of the eye, it's the inner nuclear layer. So we talk about, the terminology is called the reflectivity. You talk about if it's hyperreflective, and high reflectivity, medium, low reflectivity. This is the language you use when you describe the OCT. So normally, the structure that are hyperreflective are the nerve fiber layer, as we said, the inner segment, outer segment junction, or the photoreceptor integrity line, the external limiting membrane, and the RPE because it's full of pigments. Then the medium reflectivity will be your plexiform layer, and the lower will be the layers that have the nuclei of the cells. So the ganglion cells, the nuclear layers, the photoreceptors. An old question that used to appear in the exams was because of the colored OCT images, that if it's red, then it's hyperreflective. If it's near the blue side, then this is a weak reflection or hyperreflective. So what if you have abnormal high reflectivity? So you have something that is whiter than it's supposed to be. So let's have some examples. So here you have a very bright white line in front of your retina. So if it's something over your retina, it's an epiretinal membrane. Here you have a diffuse hyperreflective structure in your inner retina. This is most probably a cotton wool spot. You can have hemorrhages in your inner retina as well. So this is hemorrhage and OCT of hemorrhage. And your outer retina, you can have exudates or hemorrhages. This is an image of exudates in the outer retina over here. You can have a normal high reflectivity in the RPE. So this is RPE hypertrophy, causing backshadowing. So you're not seeing the lobular structure of the choroid, like if you compare it with the image above. What if you have something very low or optically blank? There's nothing there, so it can be a cavity or a cyst, like you see in the cystoid edema, or it can be a detachment. So if you have any layer that have left its place, then it has detached. It can be the retina or can be the RPE. Or you can have a projected shadow, like from over here. This is an OCT image of an aneurysm with hemorrhage, subretinal hemorrhage, both of them causing backshadowing. This is something that you would see in patients with macular degeneration, especially ones with fibrosis and long standing. This is called outer retinal tubulation. So it looks like a tube. It's in the outer retina, so it's an outer retinal tubulation. This is an OCT image showing also optically blank spaces, but involving many layers and basically extending through the whole retina. So these are most probably schitic changes or retinoschisis more than cystoid edema. A very, very, very famous question, simple question, but a very famous question in the exam. Which eye is shown in this image? Is it the right eye or is it the left eye? It seems very basic, but it's very common. I think it doesn't leave an exam. Does anyone can tell? Good, we have all the right answers. So this is the left eye. They will ask you why you're saying this is the left eye. So because this side have thicker retinal nerve fiber layer. So wherever there is the thicker retinal nerve fiber layer, then this is the papillomacular bundle, then it's going to the optic disc. And which side it's on, it is this eye. So if the thick retinal nerve fiber layer is on the left side, then this is the left eye. If it's on the right side, this is the right eye. Another question that I appeared before, what can decrease the resolution of the OCT? So the OCT seems a very, very good investigation. You can see, you can have optical sections of the retina, you can diagnose everything, but what's the problem then? What can decrease the resolution? What can prevent you from using such a very good modality? So many things can cause bad resolution, having poor tear film, dry eyes, corneal opacities, cataracts, or vitreous opacities from any kind, vitritis or vitreous hemorrhage. All of these can cause decreased resolution and decrease the importance of using the OCT in these patients. So now going on to some diseases in the OCT. I'll be putting some areas to show you what I want you to answer about. So what's wrong in this OCT? Very good answer. So whenever you're faced with an OCT image, just remember your layers, walk on the side. This is my RPE going on. So the RPE is fine, but the layers above it, oh, we have a missing area over here. This is my inner segment, outer segment junction. So we have a focal disruption of the inner segment, outer segment junction, but we have an intact external limiting membrane. Usually it can be seen in solar maculopathy. So, but of course, if I'm going to ask you for diagnosis, I'm going to give you more history. But if they're asking you about the signs, then you need to know how to describe these findings. So again, this is the inner segment, outer segment junction to remember it. This is a very common and easy question as well. What are these findings? So again, walk with your RPE, but the RPE seems to be moving up, and there's a hyper-reflective material under your RPE. So these are drusen. Very well, everyone. So drusen are soft drusen and hard drusen, depending on their pathology. And this is what I wanted you to appreciate. If you remember when I showed you the normal image, the choroid was much thicker than this. So there's reduced choroidal thickness as well. Again, another image. Walk from the sides through the RPE, doesn't seem very healthy. And then your RPE is missing over here. And going through, again, your RPE is missing. And that's why you can see more into your choroid. So the findings here would be very, very well. GA, exactly. So this is large area of geographical atrophy, and this is small area of geographical atrophy. And then you can see reverse shadowing or increased reflectance into the choroid. That you can see the vessels of the choroid because the RPE is not there anymore, blocking your light, so you can see more inside. Because this geographical atrophy can be seen in atrophic macular degeneration. Okay, anyone here? So very well, everyone. Thank you for interacting. I know many of you must have been asleep now. But we have cysts or cavities or intraretinal cysts over here. We have also something hyperreflective circular. This is a microaneurysm, and we can also appreciate the choroidal thinning. Yes, this image can be seen in diabetic patients, so this can be diabetic macular edema. We have a few subretinal fluid over here. So your photoreceptor layer is pushed up with a hyperreflective space, so this is a subretinal fluid. What about this one? Again, walk with your RPE. The RPE is left from its place, so we have a pigment epithelial detachment. The RPE detached from its place over here. It's a large one. And then when we continue with the rest of the layers, we have the photoreceptors also pushed up, but it's not very clear space, not like the subretinal fluid we saw in the previous image. So this is subretinal fluid with hemorrhage, and this is a large irregular PED, also seen in macular degeneration, but the wet type. This is the image you all like, and this is the image that comes in the exam. So again, walk with your RPE. The RPE is fine. And then when you walk with your photoreceptor layer, it's pulled up, and this is a clear space. So this is most probably a subretinal fluid. And we have the cavities over here, cystoid cavities. So this is large cystic cavities in the outer plexiform and subretinal fluid. They are mostly cystoid macular edema for many reasons. One of the most common causes diabetes, or you can have it from centroretinal vein occlusion. Another question they ask you, why does the fluid in the retina takes the cystoid appearance? So it's because the molar cells, which is like the infrastructure of your retina, they are like buildings in the middle, like this. And when there is fluid accumulating between them, it just takes the shape of the space, like we can see on the image on the left. So they appear as cystic spaces, tubes in between the molar cells. Okay, another image. There's a question on the chat. Why fluid appears black on OCT? Is it because fluid doesn't reflect light, or it absorbs light? It doesn't reflect light. It doesn't absorb it. The light just passes through. It's like a cavity. The fluid doesn't reflect the light, so it appears black. If you have any cells like RBCs, if it's hemorrhagic, that's when it becomes a bit whitish, so it becomes hyperreflective because it's reflecting more. So any ideas about this OCT? So again, in the exam, they usually ask you about the sign and then they give you more about the history if they want an exact diagnosis. So start from the sides, walk with your RPE. The RPE is fine, so we don't have a pigment epithelial detachment. We'll then walk with your photoreceptors. The whole retina is elevated from its place. So we have like a small um, space under the retina, so it's subretinal. Uh, is it fluid or is it hemorrhage? It's black, so it's fluid. So this is subretinal fluid. But what we have here, what's different, is that we have granulated changes. This is the outer photoreceptor layer. This is granulated changes over here. This usually appears in chronic CSR or central serous retinopathy. The chronicity will show you these granulated changes in the outer photoreceptor layer. Okay, what do you think about this one? Okay, so we'll walk with the RP again. You don't need to know the diagnosis, you just need to know your anatomy as we described. So working with the RPE, there is no problem with your RPE over here. But when you try and look for your photoreceptor layers, it's only present in the macula. So you have the layers of your photoreceptor layer, the external limiting membrane, and your outer nuclear layer very, very uh, fine and looking normal in the macula, but they start to disappear. So you have problems in your photoreceptor on your outer retina apart from the macula. So this is significant thinning of the outer retinal layer, sparing the fovea. This is an image of a patient who has retinitis pigmentosa, but you're not supposed to know the diagnosis without the history. But you're supposed to identify the pathology or describe it very well. So there is thinning in your outer retinal layers, sparing your fovea. Again, if someone can have a description for this image, what are the abnormal signs that you can see here? Very well, the RP is elevated, yes. We have pigment epithelial detachment. It is irregular. And then we have this tubular structure. It's not in the outer retina, so it's not an outer retinal tubulation because the outer retina is over here. We're still under the RPE. So this is a tubular structure under the pigment epithelial detachment. This is a vascularized PED and most probably called polypoidal choroidal vasculopathy, but you'll need more imaging to give this diagnosis. But this is how we would describe the sign. You have a vascularized pigment epithelial detachment with a well-defined ovoid lesion. What do you think of this one? What is the description of the abnormality you're seeing in this OCT? So again, walking with your RPE. So the RPE seems fine. It is a bit hazy to denote, but it seems that it's in its place. So there is no pigment epithelial detachment over here. But walking with the photoreceptor layers, it is pushed upwards, and this is a hyperreflective material. So if you want to be on the safe side of describing this, this is a subretinal hyperreflective material. Uh, what is the differential? It can be called called a vitelliform lesion. How can you differentiate this one from being a material or a hemorrhage? So the hemorrhage will be a bit irregular. So it will be what's the word? Sorry, the word is not on my mind, but it will not be it will be heterogeneous hyperreflectivity. So you'll find spaces, black spaces in between, but this is homogeneous hyperreflectivity. So this is an accumulation of material. Vitelliform lesions or this material usually indicates that your RPE in this area is not very healthy to take away all the waste products of the photoreceptors, so they accumulate over here. They can be seen in Best disease in the young or in some types of macular degeneration in old people. So very good, everyone. Now let's go on for the OCT angiography. So you've memorized the retinal layers, I hope so. Now let's remind you of the blood supply of the retina to understand how to read an OCT angiography. So we have the retinal blood supply. You have superficial vascular plexus, which is your retinal vessels moving in your retinal nerve fiber layer. These are the large vessels, and then they are spreading downwards, giving you the capillaries reaching out into the inner nuclear layer. So this is the deep vascular complex. And then all this area is devoid of any capillaries. It's a vascular area, which is your outer retina. And then you have the choriocapillaris. You have the choroid giving the choriocapillaris over here. So knowing where the vessels are, this is how you will image an OCT angiography. And then if you see an abnormal vessel, or if you see vessels in an area which is supposed to be avascular, this is the abnormality. If you see an avascular area in a layer that's supposed to have many capillaries, then this is the abnormality. Let's walk you through. One of the common questions that they ask about is, what is the watershed zone? What does that mean? It means that you have the retinal circulation supplying the inner two-thirds, inner half of your retina, up until the inner two-thirds of the inner nuclear layer. And then the choroid with the choriocapillaris is supposed to supply all the outer retina. So the watershed zone is supposed to be inside the inner nuclear layer. Some books will tell you it's in the outer plexiform layer. That is also correct. So it's just in between these two layers is fine. So the basic idea of the OCT angiography is that if you have a stable background and you have a moving structure, and you take lots of images of this moving structure, and then you combine the images together, you can tell where this movement had happened. So you can tell the pathway of the movements. So it depends on diffractive particle movement detection, that the RBCs in your blood vessels are the only thing that are moving in the back of the eye. So if we take repeated B scans or repeated images at the same location, the only movement is through the RBCs. So these are the areas of the small blood vessels, but it doesn't help us to know if this blood vessel is normal or not. That's why we have the OCT angiography. So here we are taking multiple images on the same blood vessels, but the RBCs are moving inside, so they give you different images. So when we combine these images that we took of the same place, we can delineate where the blood vessel is. So this is your normal OCT image. It's a cut section, as we agreed. But in the OCT angiography, you're looking at the eye in a different way. You're taking a frontal section or an in-face image. So you're looking at the back of the eye like this. So this is how the OCT angiography image will be shown. Let's see this video, which will tell you how we're taking the OCT angiography scans. We're taking scans at each line, very small line. This scan is passing over a capillary. The RBCs are moving inside the capillary, and then we will make a motion contrast image of the whole images were taken, and this will show us how the blood vessel look like. So it will show us what's happening, and we can take multiple sections, and we know what layer is having the abnormal part. So this is an OCT angiography of CNV with fibrosis, making the motion contrast image so we can see the areas where there is only blood vessels flowing, so we can really appreciate the tree of the new vessels, the abnormal vessels that are there. So what will you see in an OCT angiography outprint? What are you supposed to look at? So we have 4 slabs in 4 different layers of the retina. We have in the nerve fiber layer, which is supposed to have your superficial plexus, and then we have in the inner nuclear layer, which is supposed to have your deep plexus. So the difference is marked between both of them. You can see the big vessels in superficial plexus, very well delineated, but they get very small and like the whole thing is full of capillaries in the deep plexus. And then you get to see a slap in the outer retina where you're not supposed to have any blood vessels. This is only like shadowing from the deep plexus. And then the choriocapillaris is just full of blood capillaries moving around. So it's all of it is basically white. So you need to know what it looks like, the superficial plexus. This is the foveal avascular zone. So you have no vessels, no retinal vessels in this area in the fovea. They're just surrounding it. So it's supposed to be circular, regular, nice looking like this. This is superficial and this is the deep. So you comment on the foveal avascular zone size. This is how it's supposed to be. Its shape is regular. The perimeter of the foveal avascular zone or the FAZ is regular. There are no capillary dropout areas anywhere, and you can see no abnormal vessels. Let's see how the abnormals looks like as well. So we have this patient with diabetic macular edema. Here you can see the OCT with all the things that we have seen before, the cysts, the subretinal fluid, the exudates, and then you can appreciate the changes that happens in the diabetic patients. Now you understand what I mean with irregular FAZ and its irregular perimeter. This is the deep plexus. Can you see how big, how ischemic the foveal avascular zone is? It's basically a big area of capillary dropout. So you can also appreciate the capillary dropout areas over here with the red arrows. This is another patient with a wet macular degeneration. It's actually polypoidal choroidal vasculopathy, and you can appreciate the polyp over here. And then you can see it very well with the OCT angiography. To help you understand what you're seeing on the OCT, you have to remind yourself of the pathology. So you have abnormal vessels coming from the choroid, pushing your RPE. So they are formed sub-RPE, and then they can also erode the RPE and go into the retina, so you can have new vessels in the retina as well. So this is a slap from the outer retina where it's not supposed to have any capillaries, and you can see the new vessels that are forming over here. So this patient comes to your clinic complaining of slightly decreased vision, let's say 6/9 or 6/12. And this is the fundus image. Can you see any abnormality in the fundus image? So this patient has been diabetic for about 9 years or so. They've been having their regular checkups, but there is no diabetic retinopathy seen in anywhere. These are the shadowings from the light, but there is no lesions over here. You order your regular OCT, you can see everything's fine, the RPE is fine, your layers are fine, there's no cystoid macular edema, there's no drusen, there is no exudates. Okay, you order fluorescein, there is no microaneurysm, no leakage anywhere, no ischemia anywhere, but then you have your OCT angiography, and you can appreciate the start of the ischemic changes or the ischemic maculopathy that happens in the diabetic patients. So here you can see the irregular parameter that I told you about, and you can appreciate the capillary dropout areas where the red arrows are showing, either in the superficial or the deep capillary plexus. So let's take a break. This concluded the OCT and the OCT Angiography. The OCT Angiography did not appear in previous exam, but I'm sure they will get it soon enough. So the next topic will be the fundus fluorescein angiography. Let's take a minute and we'll be back.